let me take you back to how might we explain a relationship between the ductus and severe IVH. If we were to show that early intervention makes a difference, IVH may be a morbidity we may want to try to prevent. Well, we know from Martin Klockow and Nick Evans' studies that the presence of very low cardiac output in the first 6 to 12 hours of life is associated with severe IVH. And when Martin and Nick went and did a randomized trial of milrinone, they found no benefit. Hence, liberal reduction of afterload and enhancement of heart function does not appear to modify this outcome. Very interesting data from Shahab Nouri's group, published about 3 years ago, where they looked at the relationship between IVH and what happens to cardiac output. And what they actually found, if you look at the graph and focus on the top left, what you can actually see is that the babies in black had a normal cardiac output, which remained normal, and the IVH rate was low. In the babies who developed significant grade 3-4 IVH, their output started low, and there was a fairly rapid progressive augmentation in cardiac output that happened in the 6 to 12 hours prior to the evolution of this IVH. So, is there a modulator role of the ductus in IVH? Does it make sense? And the answer is yes. After birth, in the face of significant systemic vascular resistance, the LV may fail, and cardiac output we know is low, potentially subjecting the brain to a hypoperfusion state. At the same time, if the ductus is open and your pulmonary vascular resistance falls, the amount of blood that flows across the ductus will increase. The amount of blood that returns to the left heart will also increase, leading to an augmentation in preductal cardiac output, therein potentially setting the scene for an ischemia reperfusion cycle. Secondly, what happens when you take away prophylactic indomethacin? Well, from Melissa Leibovitz's recent publication with Ron Kleiman in a center that practiced very aggressive management of the ductus arteriosus and stopped, their data showed very convincingly that the proportion of babies, particularly less than 25 weeks, with large PDAs was significantly increased, as was their risk of chronic lung disease. And when they looked at what was the major determinant for that change in chronic lung disease, it was the presence of a large PDA. This is very interesting because when we looked at our Toronto data and we looked at over a large cohort of 600 babies and compared babies who required surgical ligation versus those that required medical therapy but eventually closed, what you can see from the graph is the top bar in yellow are the babies who required surgical ligation. If you follow back to the first day of life, you can see that even by day 1 to 2, there was a separation between the groups. So moving forward, we need to evolve. Nobody here is going to go back to using a map, okay? We all are very happy with our navigation systems. If we think of how we evolved in other domains, okay, medieval neurocritical care, I don't think this is the type of thing we do today, kind of drilling the brain to try and find out what the problem is. We have a degree of sophistication in how we monitor the brain, both with electrophysiologic and imaging. From a lung perspective, we monitor in a very comprehensive manner. How about from a cardiovascular perspective? How can we evolve to better answer the question? Sometimes it's a sentinel case that provides you some insights and provides you the support to move forward. And this particular case in Toronto was a mother born preterm at 28 weeks gestation who was very preeclamptic. The baby was in very poor condition at birth, required multiple intubations, was in a community hospital, eventually got intubated, but had very poor start. The baby was given surfactant and did well from a respiratory perspective, but then developed a low blood pressure. The baby was given dopamine, the blood pressure remained low. We increased the dopamine, the blood pressure is even lower. Therein lies one of our problems in neonatology. We don't necessarily look in the mirror and say, what we're doing is wrong, we need to stop it and do something different. No, we add in another therapy, okay, without any science to justify it. And now we have a baby who is very sick with lactic acidosis, but has a normal respiratory pattern. We had a discussion on the morning rounds in Toronto about this 10-hour baby. Many things were proposed as the reason: ischemia, heart dysfunction, sepsis, and so forth. A resident asked me, what about the ductus? And in a very evangelical manner, I said, this cannot be the ductus. Okay? Beware of evangelical things. So I texted my colleague Reagan Giesinger and said, Reagan, can you go scan the baby? I think the baby's probably got some RV or LV dysfunction. And she comes back with a beaming smile. Here you can see that this child's got a ginormous ductus like the channel tunnel. And what was most interesting was the degree of disturbance hemodynamically. The pulmonary vein flow was high. QPQS was almost 3:1. There was significant flow reversal in the descending arch and so forth. So we decided, let's treat. We gave the baby indomethacin. We implemented conservative measures as well. I believe that conservative therapy is also supportive to medical therapy. The hemodynamics improved. The baby got extubated within 24 hours. Again, one has to be careful of single cases, but sometimes they give you insights. My esteemed colleague who I'm debating actually agrees with me that actually early echocardiography is a good thing. Mortality was lower in infants who received early echocardiography. In that analysis, Matt will tell you that the babies who actually had a diagnosis of a PDA did not show that significant benefit. But the fundamental question that I will argue is, did we do the right thing in how we assess them? And the reason being is that in the transitional periods, many things can go wrong. Here are 3 examples of 3 preterm babies who are hemodynamically unstable in the first 24 hours of life. The baby on the left has an empty left heart because he's on a mechanical ventilator with way too much mean airway pressure. The one in the middle has severe right ventricular dysfunction. The one on the right has significant septal hypertrophy as an infant of a diabetic mother. If you give these babies prophylactic indomethacin, you may not do very good to them. So we need to identify what is the problem. And there are data that suggests that screening with echocardiography in the first week of life can be beneficial. The French data shows very clearly that early echocardiography can prevent mortality in centers that actually use this. Some data from the UK show that when they look back at the babies that they treated beyond day 7 of life, and particularly if you look at the ones that are less than 26 weeks gestation, those babies were obvious, at least in terms of diameter. If that's all you have, it shows that there's something there. But diameter on its own is not good enough. How can we move beyond diameter? Well, if you look at Martin's DETECT trial, and the DETECT trial was an important study because at least it provided some evidence that a thoughtful early look may actually help identify a population that might benefit. What they did, they randomized babies to treatment or no treatment based on diameter, and what they actually found was that pulmonary hemorrhage was reduced from 26 to 9%, late treatment was reduced. The study was underpowered for the primary outcome of death or IVH because they ran out of indomethacin like many other places did. But what's most interesting was if you actually look at the incidence of severe IVH, it was 3-fold higher in the placebo group. Can we do better than diameter? And the answer is yes. This is our natural history study that we did between Canada and Ireland, looking at the physiologic markers that are associated with shunts over the first week of life. And what you can see is that babies fall into 2 categories. The shaded bar, the lighter shaded bar in which the ductus closes, you can actually see fairly stability in most of these markers. In the ones in which the ductus remained open, you can see that pulmonary vein diastolic flow increases, cardiac output increases, and systemic perfusion is compromised in the first week of life. So there are many babies that can have significant physiologic disturbance. And Afif showed quite nicely that a composite score, including gestation and some of these markers, predicted death or BPD with a degree of precision better than gestation alone. So my final piece, I want to share some preliminary data that might help us move forward. Back in the early 2000s, I visited Japan, and I was struck by the fact that the Japanese were using echocardiography in a very thoughtful, dynamic manner. And interestingly, their data for babies born less than 24 weeks gestation showed that their rates of ligation were only 11%. The rates of IVH were 22%, which was better than some of the data for the Western world at higher gestations. In Iowa, we also have a fairly high survival rate, which is incredibly impressive and due to the degree of engagement by faculty in providing precision of care. But since I've arrived in June, we've started to perform more early targeted assessments of the ductus in the first 24 hours of life. And what we've identified is not kind of completely surprising. Firstly, some PDAs are closed. Secondly, some babies have severe heart dysfunction and pulmonary hypertension. But we've found babies that have large shunts. The bar in the third, which is the orange bar, are the babies that we have treated in the first 24 hours of life based on high volume shunts. Those babies have a 0 rate of severe IVH. These are tiny babies. The ones on the right, who also had similarly large shunts, in whom a decision was made not to treat, have a 75% risk of grade 3/4 IVH. Very preliminary. Please don't take it away as pure science, but it certainly suggests something important. So, my summary points. Prophylactic indomethacin reduces IVH and surgical ligations, but is imprecise. Centers which stop using prophylaxis have higher rates of hypotension and higher rates of mortality and BPD. Early screening echo is associated with lower mortality. Targeted therapy at 6 hours provides preliminary data that you can reduce pulmonary hemorrhage, late need for treatment, and perhaps grade 3/4 IVH. Thank you very much.